Thank you for participating in the CAMPS Medi-Cal rate reduction webinar. This webinar is being recorded and will be made available on our website. An email with a link to the recording will also be made available in the next several days to each registrant for this meeting, along with a copy of the handouts. You are currently in listen mode. There will be a time at the end of the call for questions and answers. Please keep your questions until the end of the presentation. If you wish to ask a question, simply raise your hand by using the toolbar on the right-hand side of your screen. And if you can't see that, there is a little red arrow that will help you to expand the screen to see some additional options. You can either raise your hand using the tools in that screen, or you can type your question in the question box in the same toolbar. At the appropriate time, Bob Achermann, the presenter, will call upon you or acknowledge the question to the group and provide a response. If he calls upon you, you will be unmuted so that you can actually present your question. And now that we have the formalities out of the way, I'll turn it over to Bob Achermann, CAMPS Executive Director.
Great. Good morning, everybody. Thank you for taking the time to be on what I think is a very important call and a very important message to the DME and medical supply community. So I'm going to do a little bit of history here in terms of where we are and how we got here. Some of you may have heard this part before, and I apologize for that, but I think it's important to give some perspective as to what the political dynamics are in this process and from whence we came. For those of you who attended the recent CAMPS annual meeting in Los Angeles, some of this you've heard before, but some of it will be new and certainly be updated in terms of where we are now as we move through the budget process. At the end of the presentation, I will also do an update on the dual eligible transition, the Medi-Medi population, to give you kind of a a snapshot as to where we are now in that process, and talk a little bit about the impact of the Medi-Cal rate reductions on the managed care community. So, with that, let me start with looking at back to the when the first reduction was actually begun. So if we go back to 2011, the state was in a very bad fiscal situation. We were dealing with budget deficits of $20 billion, significant in terms of an overall budget picture that was about $100 billion at that time. So really at a time where there were massive deficits and a need to address the various categories of state spending and try to at least balance the budget going forward as best they could. So when you look at state spending, about 90% of it is on automatic pilot, as they say, in terms of education spending, social services, prisons. Those three areas account for about 90% of the state budget. Prop 98 in California, approved by the voters, also requires that every new dollar of state revenue that comes in, a certain percentage goes automatically to fund education. So you've got a lot of things in the budget process that really restrict what can be done in terms of creativity. Medi-Cal obviously is a very significant part of state spending. The slide says 6 million enrollees. We're now probably going to be getting up to about 8 million enrollees by the time the Medi-Cal expansion is done via the ACA. That $16 billion cost is going to increase. The new enrollees are funded through the federal government for a period of time, but eventually the state assumes responsibility for that. So we used to say that 1 in every 6 Californians was on Medi-Cal. By the time the ACA rollout is finished, we're probably looking at 1 in 4 Californians as being eligible for the Medi-Cal program. So the legislature dealt with this massive budget deficit by looking at, again, the significant program areas, and Medi-Cal was in the loop for getting its share of a reduction. So they adopted a 10% provider rate cut that applied to just about all provider types. There were a couple of exceptions, but very narrow at the time. When this reduction was adopted, unlike the prior reduction, which sunsetted or ended and reverted to a 1% or a 5%, this 10% reduction came with additional provisos in the statute that allowed the department to make exceptions to the reduction, to adjust the 10% to a lesser amount if they saw fit. So a lot more flexibility in how the department could address that in terms of what has evolved into access issue questions, but again, more flexibility. The budget called for that the 10% reduction to be implemented as of June 1st, 2011. In order for the state of California through the Medicaid program to change what it does in terms of payments and coverage of services, it has to file what is known as a state plan amendment or a SPA with CMS to get approval before they can actually go forward and make changes. Since it is a matching fund program, meaning the federal government provides approximately 50% of the state Medi-Cal costs, you have to go through that process via CMS in order to make sure that they are aware of what you're doing and how you're doing it. So the SPA submitted for this 10% rate reduction was actually approved by CMS then in late September 2011. At the time, the department indicated they would make that retroactive to June 1st, 2011. They also announced that in terms of doing this kind of change and changing the systems at Xerox in terms of payments, making those adjustments, that all takes time. They announced in September that they would implement by the end of December. So at that point, legal action was initiated. The first one that went forward was a pharmacy group who obtained an injunction in federal court in December of 2011 to prohibit the implementation for pharmacy. CAMPS decided to join a coalition led by the California Medical Association to also seek an injunctive relief and prohibit implementation of the 10%. Historically, we had not made that decision at some times because of obviously the cost of participating in these coalitions. It's a pay-or-play approach. The medical association, the hospital association, is not going to bear the burden of the legal expense for other types of providers unless they agree to share that. So CAMPS, having had that experience in trying to intervene in the 2009 rate reduction, we got into the party too late. And even though we were allowed to join the then injunctive relief, by the time we got in, it was pretty much eliminated. It went back to a 1% or a 5%. So the board of directors for CAMPS this time decided we needed to raise those funds. We needed to reach out to our members and make sure we're at the table so that any injunctive relief that was provided to providers would include DME and medical supplies. So we agreed to provide roughly $85,000 in funding to the coalition to pay for the attorneys involved in getting the injunctive relief. We also provided declarations from several members about the impact of the 10% reduction on providers, and an injunction was granted on the 10% as of January 31st, 2012. The DME cut actually had begun on December 22nd, 2011, but only lasted for that period of time. Once the injunction was granted, the cut stopped, which was very positive, obviously, for all of us. As all of you are aware of the legal process, it's never over till it's over, and there's always appeals that can be made, and typically losing parties do appeal. So the Department of Health Services went forward with an appeal to the Ninth Circuit Court of Appeals. At that point, a three-judge panel, and that's typically how these things are decided. A small group of judges basically hears the case, and in that case, they reversed the injunction. The injunction went away. The 10% could begin. And that was in December of 2012. At that point, the coalition again decided to take every possible legal avenue that was available to us. We filed what was known as an en banc appeal, which is an appeal to the entire panel of the Ninth Circuit Court, which is about 35 judges. That appeal was denied. The last step in that process, having lost our injunction in the Ninth Circuit Court of Appeal, was to file what is known as a writ of certiorari with the U.S. Supreme Court, which asked them to take the case and hear it on a national basis. Those writs are not routinely approved, very limited in terms of the percentage of cases they take, and they typically only take cases where there are major disagreements among the various courts of appeal as to what the law should be. So that was really a Hail Mary in terms of filing the writ, but we wanted to do it because 10% obviously is very important to us. Unfortunately, that writ was denied in July of 2013. So our legal avenues were exhausted in terms of trying to enjoin this reduction. So in 2013, we supported bills in the California legislature, which would have either eliminated the cut or stopped the cut. There was support in both houses, the Senate and the Assembly. There were two legislative vehicles that were amended and were moving in the process. The governor was very resistant to, at that point, changing anything in terms of the difficult budget decisions that were made in order to right the ship. Those two pieces of legislation, it didn't end up getting to the governor's desk for signature. Part of that was the Senate leadership at that point was looking for other types of program relief unrelated to Medi-Cal. Senator Steinberg he was the president pro tem of the Senate, is a very big proponent of mental health programs and increased funding. That was more of a priority for him than providing relief on the 10%. So nothing really happened that year. The legislature is controlled by the Democrats. You have a Democrat in the governor's office, but Governor Brown has been very much one who has wanted to show great fiscal restraint in terms of undoing the difficult budget decisions, as I said again. Also with Prop 30, you had some temporary increases in sales tax, income tax, et cetera, that were intended to provide stability to the state budget, and he was very much against wanting to make any other changes in repealing reductions that were done in a more difficult time. The budget process is one, as we all know, that fluctuates in terms of revenues. The capital gains income the state of California receives is a very volatile revenue source, and good years mean you get a little bit more money, bad years mean you don't get that money in terms of how the stock market gyrates at times. So those are some variables that he thinks are very important in terms of what you want to do in an overall budget picture. So we then get to the point where the department announces implementation of the prospective 10% reduction, meaning going forward, they were going to do that by provider type. And so for DME and medical supplies provided by a DME provider, that reduction occurred on October 24th, 2013. If you had a pharmacy provider number, then the medical supplies billed by the provider would not be impacted initially until January 9th, 2014, eventually delayed until February 7th, 2014. So those reductions are now being occasioned upon your claims as they're being submitted. We also know that from recent experience with the sales tax change from Prop 30, that if any of the claims between June 1st, 2011 and the current time are reprocessed for any reason, Xerox is going to apply that 10% to that reduction. And we saw that it's an example of good news, bad news situation. So medical supply claims that were subject to sales tax payment were reprocessed here in February because Prop 30 provided for an increase, a 0.25% increase in the sales tax. So they wanted to make sure that those claims were properly paid as of January 1st of this year. So they adjusted the sales tax to providers. At the same time, they took those claims and re-adjudicated them based upon the now 10% reduction. So some people have seen an additional take back there. We've talked to Xerox and the department about that. Technically, they are in compliance, but it becomes very problematic and difficult for providers who are seeing unexpected reductions through a sales tax adjustment. So that is out there. There was some relief for the pharmacy community in terms of creating a process within the department to exempt certain drugs from the 10% reduction, or really the 5% reduction. Pharmacy had an ongoing 5% reduction. So they've exempted a fair number of drugs from the new 5% reduction. Usually those that are more expensive, some of the more generic and common drugs may not be impacted, but I think it's really provided a substantial amount of relief to many pharmacies in terms of reducing that actual reduction that they're going to see. And that was done via, again, a SPA, a state plan amendment, that was approved by CMS. That's why the 10% perspective was delayed until February 7th, because the SPA was adopted shortly before that. Those of you who provide enteral formula saw an additional 5% cut, again, because there already was a 5% reduction in effect, so that was triggered as of February 7th as well. We've had a lot of conversations with the Department of Health Care Services about the clawback, obviously going back to June 1st, 2011, and recouping all the excess payments of that 10% amount until the implementation date has been out there for some time. We have had numerous conversations with them in terms of what the timing for that would be. The most recent information we had was that it would occur no earlier than 60 days after the last prospective cut, which now was February 7th, so technically could begin in this month of 2014. We have seen no evidence of that yet. As I'll talk about what's going on now currently in the legislature, I think we're probably not going to see any implementation for a while, but that is a day-to-day affair in terms of our communications with the department. The process for recoupment would be that providers would be notified via letter of the total amount of the clawback at risk. So Achermann Medical Supply would receive a letter from the department saying, we've calculated that you've been overpaid by X thousand dollars, and we will begin to recoup those funds via new check writes and new submission of claims. Have been told in the past that it will be done over a 24-month period. So effectively, providers would probably see a 15% reduction in the payment amount for the particular item. And that would be done, on a provider-by-provider basis. There would be hardship exemptions that could be obtained. And as I said, this is where we are right now. We don't know whether it will be done exactly this way or the timing, because we're not there yet in terms of implementation. But that is the clawback process. It is physically them reprocessing all these claims. So all the claims that were paid back to June 1st, 2011 would be resubmitted into their system, and they would be adjusted by individual provider. So it's we're talking about millions of claims, obviously, that have been processed during that time. It's likely that they would do that reprocessing by provider type. So obviously the question for us is, where do we end up in terms of the queue for which providers go in first? We are a relatively small number of claims, and I'm guessing that the department will probably put us pretty early in the process in terms of initiating the clawback by the provider type. But again, not yet known, and we will keep you aware of what's going on, obviously, as we hear about it. So as we look now, skip that slide that we just talked about, and we look now where we are in 2014, 2015 in terms of the current budget deliberations. As a result of Proposition 30 and as a result of the general improvement in California's economy, the governor's January budget proposal is much rosier than we've seen in the past. We have moved from annual deficits to now the prospect of possibly having a budget surplus of perhaps $4 billion, perhaps $6 billion, perhaps more. I'll talk about where we are in terms of how that process plays out. But substantial improvement in the California economy does not address some of the long-term issues that we have in terms of unfunded liabilities for pensions, et cetera. But the legislature pretty much routinely ignores those kinds of long-term liabilities and focuses on current revenues and expenses. In the monthly reports that the controller makes about receipts, for the last 6 months, we have exceeded in most months revenues from sales tax, revenue from income tax. April obviously will be a very big month for the state in terms of what income tax revenues look like, but a much rosier picture. You have a governor who still wants to constrain the enthusiasm for increasing spending in areas, undoing reductions that were done, but he's going to have pressure from his Democratic colleagues to make some changes. So the good news in the governor's January budget proposal, for the budget that would take effect on July 1st, 2014 through June 30th, 2015, eliminates the retroactivity or the clawback for some providers. The biggest group included there is physicians, and pharmacists were also exempted on certain drugs. Unfortunately for us, there is no relief for DME and medical supplies, so the retroactivity still remains. and the department has indicated that they are making exemptions moving forward based upon impaired access. That has, that examination of access has been very narrow in terms of how the department calculates the number of providers and who's available to provide DME and medical supplies. It's a very, I think, as I always say, a 10,000-foot approach. How many providers are enrolled in the Medi-Cal program for DME and medical supplies? There are a lot. The question is, how many of them are still there and doing business? How many of them are taking new Medi-Cal patients? And how many of them are providing the full range or even a broad range of medical supplies or DME? We think that is significantly changed over the last year and a half based upon both the Medi-Cal reduction, Medi-Cal Managed Care movement, and the ability of some providers to be in networks to provide services to SPDs, and obviously the impact of Medicare competitive bidding, which has further constricted the ability of providers to service Medicare patients. So we think that assessment of access needs to be done more by specific types of providers, be it custom rehab, be it medical supplies, be it enteral. There's a very much narrower pool of providers out there than there were a year ago or even 6 months ago. We think the department needs to make that kind of assessment. But at this point, what they've told CMS via the SPA is they simply look at how many people are enrolled in the program as providers, as opposed to that more deep down analysis of who's out there and what are they doing. So the exceptions do not include us as of this date, and the governor's proposal, which goes through the legislature in the budget subcommittees and committee, and then comes out the other end as a legislative budget proposal, reviews his suggestions and makes changes. So in this same year, we now have some reason for optimism, some reason for enthusiasm in terms of a broader application. You have Assembly Bill 1805 by Assemblywoman Skinner and Assemblyman Pan. Assemblywoman Skinner is the chair of the Assembly Budget Committee, which obviously is a very important role. Dr. Pan is a pediatrician and is the chair of the Assembly Health Committee. AB 1805 is a great bill that all of us would applaud for in a heartbeat. It would eliminate the clawback for all providers and also eliminate the 10% reduction going forward. So that bill has been introduced in February, will be heard in the Assembly Health Committee later this month. It will then move to the Assembly Appropriations Committee, where it probably will stay. And I'll talk about that in a second here. So CAMPS obviously supports it. As I get through farther on presentation, I'll talk about what you can do to indicate your support as well. But it's broadly embraced by the provider community. The CMA has a coalition, a broader coalition of both providers, public employee unions, other patient advocacy groups, We Care California, which is supporting this bill and looking for elimination of retroactivity for all providers, again including us, and eliminating the prospective 10%. So this bill is reflective of that attitude, and we have two Democrats on the Assembly side who have shown a great deal of enthusiasm for moving forward via a separate vehicle. It will likely not move on its own because the cost of the bill will be significant. This is an issue that will be resolved in the budget process, meaning it's going to happen there or it's not going to happen because the fiscal implications of the bill are so significant that it will not move out of the Appropriations Committee without being funded. So it is an important vehicle to raise the issue and to let legislators know what's going on in the community and how it impacts providers, but it will not be the vehicle that's going to solve this problem. So if we look at what the clawback means to us, if you look at that entire 3-year period from June 1st, 2011 to either October 2013 for DME or February for medical supplies, the total general fund cost to the state of California to not take back that 10% over the 3-year period is about $37 million, meaning you would double that with the Medicare contribution to it, but a $37 million general fund cost for the program. The annual savings that is achieved in the state budget by applying the 10% for all providers and managed care is about $427 million general fund. And as I said, the doctors are already out of that take back, so that's about 50% of that amount, but it gives you some perspective of the cost here. If you're looking at a surplus of $4 to $7 billion, that would be an appreciable part of that if it would be used for that purpose. The budget includes ongoing savings from the 10%, so that comes out of the governor's calculation. You're looking at a political dynamic that will involve a number of priorities. Medi-Cal is not the only one. You've got a governor who wants to have a rainy day fund that puts money aside for those eventualities that do occur that are unanticipated during a budget year. He wants to set aside about $1 billion for that purpose. You have pressure in home supportive services, which the governor has proposed a cap of 40 hours per week for any caregiver in the home setting. That is drawing a lot of attention from in-home supportive service workers and their unions, and a lot of pressures, education funding, community colleges, all kinds of things that have been hit during the years when we had difficult budget times. So that's where we are in terms of the budget proposal and what the impact is for us. When you look at that $37 million for the clawback for our services, it is a small amount of money in a what is a 16 or probably now $17 billion program, but it all adds up, and other providers were not included in the retroactivity either. So it is peanuts in terms of the overall cost, but it all adds up and it's all becomes substantial at the end of the day. So we need to bear that in mind as we look at what we're doing here. So the decision as to how this is going to happen, or if it's not going to happen, meaning are we going to eliminate the clawback, is it going to be extended to DME and medical supplies, or are we going to eliminate prospective 10% reduction, really falls in the bailiwick of the Assembly and the Senate Budget Subcommittee. So I've attached here some material we put together that lists the members of, the key members of the Senate, the key members of the Assembly that are going to be looking at this. We've also included the Senate and Assembly Budget Committee chairs. So you've got Senator Leno there from the San Francisco area. I basically have put down, where these members are from. It's a pretty short list of people. The subcommittees only have 3 or 4 or 5 members on each subcommittee. You can find them and contact them very easily by going to the websites that I've included in the letter, the www.assembly.ca.gov or the Senate equivalent. You can type in your zip code. You can find out who your legislator is. You can get contact information. So the process of reaching out to them is really, it takes some time, but it's very easy to do. And quite frankly, you have to do it now. I think I'm pretty good at what I do in Sacramento in terms of advocating on behalf of the industry, but I can't do it by myself. And this is an issue that members need to hear from their constituents. And believe me, they do respect what constituents tell them. There is not a lot of opposition to undoing some of these pieces. So that's not the problem. It's not that you're going to be met with resistance or arguments back saying, I believe the 10% cut is appropriate. I believe the clawback should be done. These decisions were made strictly based on fiscal issues. When that cut was adopted in 2011, nobody said Medi-Cal rates are excessive. That wasn't part of the equation. It was simply a matter of finding dollars to balance a budget. So, it's imperative that you do this outreach. You can, once you find if you're a constituent of one of these budget subcommittee members, by all means contact them because they're going to be the first line in terms of a vote on this. But you should contact all of your legislators so that they all hear from their constituents about how important this is, because the budget debate will be based upon, in some cases, who's yelling the loudest, who's making the most noise, and DME and medical supplies being a relatively small part of the budget process. Some people don't know a lot about you. They don't know about the valuable services you provide. They don't know about who you are in the community. They don't know about how long you've been in the Medi-Cal program. You need to let them know that, and you need to let them know what it means to you as a provider to be subject to the 10% recoupment over a 3-year period. And I just put together, I could do template letters, but having everybody get the same letter is not as effective as somebody reaching out and just telling them what it means to them. So as you reach out to your Assembly and Senate members, tell them who you are, tell them about your businesses, tell them how long you've been in the Medi-Cal program, tell them about the number of employees and services you provide, and then tell them what it means to have someone come back 3 years after you've paid your bills, you've paid for your goods, you've paid your employees, you've paid your taxes, and does someone come back and say, well, we want to get 10% back of what we paid you for a 3-year period? It's outrageous, it's unworkable, it's unmanageable, but they need to hear from you to get that message that, what it means to local businesses, sometimes small, sometimes medium, sometimes large in their areas, and what that means to you. And will you survive this process? Because the reality that I tell all the members is this recoupment would come out of prospective payments, meaning new claims. They're not going to go back and take money from providers directly. They're going to take it as new claims are submitted. They're going to reduce the amount of payment that they're giving to you. For those companies who are no longer in business or not servicing Medi-Cal, they're not going to be impacted by this. And the state's not going to recover as much money as they think they're going to recover because these people will not be submitting new claims. People, legislators need to understand that this is not, another reason why it's not practical is it's not going to work. So I really encourage you to do that. We made the rounds yesterday with a couple of CAMPS members who came up to Sacramento. We spent the day visiting a number of staff for the Assembly and Senate Budget Subcommittee. Very good discussions. They all get it, but we need to make some noise, and this is the opportunity for you to do that. And I can tell you, we're not going to be successful without that involvement, without them realizing that you're out there and that you're impacted by this in a very dramatic way. And going forward, whatever profit margin might have existed in some of these items, a 10% reduction basically eliminates whatever profit does exist. So it's a little time on your part. This next 6 weeks or so is probably crucial to the process. The May revise will come out obviously in May, about the middle of May. It will then will basically update the governor's budget forecast and the actual experience in the current fiscal year. So again, what's the amount of money that we really have as a surplus? How much higher has it gotten? How much more money is available for the legislature to use to take care of some of these issues? That's going to be very impactful for how the legislature and the governor looks at the 2014-2015 budget. Will it include some additional exemptions from the clawback? It's possible, but I'm not holding my breath on that. Again, we're a small cog there. The department, as I said earlier, doesn't believe that there are access issues with our provider type. And quite frankly, their general perspective sometimes of the industry in terms of some of the issues they've had in the past with suppliers, the fraud and abuse that exists both in Medi-Cal and Medicare, doesn't bring us to the top of the hit parade in terms of looking for relief during that process. So it's important that we act now and you make these contacts over the next few weeks to let your legislators know that you're out there and what this means to you in terms of your survival. What will happen here remains to be seen. Obviously, as the budget process plays out, you no longer have a requirement for a 2/3 vote in California to pass a budget. That was changed a couple of years ago. So the days of not having on-time budgets are gone. The last couple of years, they've adopted budgets by June 15th. That's a simple majority vote now. And in fact, up until some of the recent problems in the Senate with indictments, there was a 2/3 majority of Democrats in both houses anyway. So the issue of 2/3 vote being a hurdle that couldn't be met has pretty much been done away with. But in any event, simple majority vote. And at some point, there will be discussions between leadership in the Assembly and Senate and the governor, and they will craft a budget deal that will be sent to the floors for adoption. And they will, they could be looking at our particular issue in a variety of ways. They could eliminate retroactivity and not deal with the 10% prospective cut and keep that in place. They could deal with all of it They could deal with none of it. They could do, as I heard yesterday from one of the budget staff, there may be a recoupment over a longer period of time. So maybe you eliminate the 10% prospective cut, but then you do recoupment not over a 2-year period, but over a 5-year period. And maybe you take a lesser amount back. So there's all kinds of possibilities, and it becomes a numbers game. But for us, again, being redundant, we need to get our voices heard, and you need to register on their feedback scales that this is something that they need to prioritize in terms of a budget solution. So that's where we are. The next 6 weeks are key to what happens. So let me move on now pretty quickly to the Medi-Cal duals transition, which I've talked about at a couple of conferences. I think we did a separate webinar on this as well, so most of you know this is a project that's been under consideration now for a couple of years, a demonstration project in multiple states, including California, would move Medi-Medi eligibles into managed care plans. About 1,100,000 patients at SPDs went a couple of years ago. Why do you want to move the Medi-Medis? Because they're the highest cost beneficiaries in the process. They account for, I think, 60% of overall spending, chronic conditions, elderly, et cetera. So that's why the department wants to move them into a managed care process as opposed to fee-for-service. Also referred to as the Coordinated Care Initiative, integrated model of care, reduce the fragmentation that fee-for-service often provides. Initially proposed for 8 counties, initially going to begin March 1st, 2013. That didn't happen. And again, you need to submit this for CMS approval via the SPA process. So a lot of details had to be provided to CMS before they could move forward. A little bit about, Medi-Cal. You either got fee-for-service or managed care. Managed care has 3 different models. 14 counties have county-operated health systems where it's run by a public agency. Geographic managed care exists where beneficiaries can choose from a variety of health plans. There are 2 GMC counties currently, and the 2-plan model where Medi-Cal contracts with 2 plans, typically a local plan and 1 commercial. And there are 14 2-plan counties now in California. Managed care exists in 30 of the 58 counties, but the intent of the department is to move all beneficiaries into managed care as soon as possible. The more rural areas, that's more of a challenge, but that definitely is on their to-do list and something they're focusing on. A lot of stakeholder discussions, as you might expect, between both the provider community. Camps has been participating in some of those. A lot of patient advocacy groups that are concerned about this transition, the ability of patients to maintain access to the providers of choice, the ability of managed care to deal with more complicated patients with multiple medical conditions, multiple specialists, et cetera. So a very concerned, much more cautious approach after the SPD experience and transition there. Submitting the final, which I think they're pretty much there. I'm not quite certain at this point whether that has been signed off entirely, but I know most of the pieces have been agreed to. Population is more complex, as I talked about, and much more concerned about the adequacy of provider networks, that they want to make sure there's enough patients, or enough providers out there to service these patients and make sure there's not going to be gaps in services. In terms of these are the 8 counties, and this is a list of the care providers within each county. LA, HealthNet, LA Care, Care First, Care More. They've expanded that portfolio of providers that are eligible to service these patients. Orange County, CalOptima. Some of you may be aware that they had issues with quality, where they're kind of on hold now, pending a readiness review. So I'll get to the timeline here, but LA and Orange particularly have had issues with compliance with quality standards from CMS's review. So they're kind of a little bit on hold there. So it's going, again, a lot slower than anybody had imagined. You can look at these. There's a website, www.calduals.org, where they post a lot of current information. You can keep up to date on your individual county and where things are in terms of the process. Again, a pilot project for 8 counties, but these are the lion's share of the population in California. These are 8 of the largest counties in California, so more than a pilot. There's 8 counties on the map in case anybody's geographically challenged. You can see where they are in the state of California and their relative size. A couple of slides here that show you the timelines now, and these are up to date, but I encourage you to pay attention to your individual county because the dates can slip. They're definitely moving towards now beginning with voluntary enrollment or passive enrollment in most counties. They're not making people make a decision. So you see in LA, for example, there you've got voluntary enrollment April through June of 2014, passive enrollment with those care providers based on birth month no earlier than July 2014. Again, for this segment, a Medi-Cal beneficiary can opt out of the Medicare side of managed care, meaning they can stay in their current Medicare Advantage plan, or a fee-for-service system. They can't opt out of the Medi-Cal managed care, so they have to go into the managed care part for their Medi-Cal benefit, but they can't opt out for the Medicare portion. I won't spend a lot of time here. This is you can look those at your leisure and see your individual county as to where they are. Next slide shows Alameda passive enrollment based on birth month, meaning each beneficiary based upon their birth date that month then triggers them to make a decision. They're getting letters in advance from the department warning that this opportunity is coming, and then more information about when they have to make a decision. If they, once you get past passive enrollment to mandatory enrollment, the beneficiary doesn't have a choice if they don't make one, meaning they're auto-enrolled by the department into one of the service providers within their county. So this is where the counties currently sit. And I said again, check that site. We'll try to keep you informed as things progress, but it's going much slower based upon a lot of hesitation, both for the department to make sure they get this right, and also with the legislature expressing concerns about whether or not this is going to be successful and work. So that's, I think actually there's one slide missing that I'll just do orally and I'll include in the final that goes out. In terms of Medi-Cal managed care, what happened with the 10% was as of last October, managed care plans were given an actually equivalent reduction of the 10% based upon the 10%, meaning the cap rate paid to plans was then adjusted to reflect a 10% provider rate reduction based upon those Medi-Cal changes. They did not include physician specialty services, but include pretty much everything else, which would include DME and medical supplies. Now, what an individual plan does in terms of their payment rates is really up to them. They are required to provide the same general level of services that Medi-Cal fee-for-service does, but they have flexibility in terms of what they pay for those services, meaning in both directions. They could increase rates, as some of the plans have for some primary care physicians in order to attract them. For some specialty services that are harder to get, they can also pay less than Medi-Cal rates. And I know I've heard from some members who are dealing with Medi-Cal plans that are paying less than the Medi-Cal fee schedule. So long as they maintain access to sufficient numbers of providers and they maintain that in terms of the department review, they have flexibility there. So what will happen in terms of the 10%, if it goes away, if it continues, if it, as it has been implemented, what's going to the impact going to be? It's really going to depend upon the individual plan as to what they do and how they prioritize any changes. Being a smaller part of the overall healthcare cost system, they may not focus on DME and supplies right away. On the other hand, they might do that and simply, reduce rates to 90% of Medi-Cal or something along those lines. They have flexibility there. And we have to monitor the situation in terms of what's going on. So the last slide I have is asking you to get involved. Camps, we're still here. We're struggling. We've spent a lot of money and had generosity from some members, but not from all. We needed to go down that legal road in terms of defending ourselves. Ultimately, did not have ultimate success, but actually, kept from happening for multiple years. And I think hopefully set the stage for getting that repealed by virtue of the fact that it hasn't been done. So That has come at a cost that we have funded. We need help in that regard. We need you to make contributions and assist us with that. I know it's tough times for our members too, but we're the ones who are advocating for you at the federal level. We're the ones that are taking care of these issues as best we can. Tough times, but you need to participate because this business and this industry is going to continue to be active. There's more patients coming forward in Medi-Cal, so we're going to be here. We need your help in making sure that we're at the table and continue to focus on the needs that are important for you. So that's the end of my prepared comments. Happy to answer any questions. I think you were instructed on how to raise your hand and be taken off mute so you can ask a question, or certainly type one in on the right side there as well. Everybody understands this perfectly and there's no questions. I'll give it a couple of minutes if anybody has anything they want to ask.
Okay, so we do have a couple of questions that are coming in online. Bob, do you want me to read those off to you?
Yeah, I don't see them. Yeah.
Okay, so from Diana Guth, the question is, how will the clawback work with the upcoming Cal duals? And you may have already answered that question. It came in a little bit earlier.
Yeah, that's a very good question, Diana. I don't know since that hasn't happened yet for the most part, but that is a part of that process. Those claims that go to Medicare First as primary. I believe that when we had the last presentation in Los Angeles at the annual meeting from Harbridge Consulting, who's the outside consulting firm, they did not have an answer to that question either. So that's one I'm going to pursue with them. But I can't answer it because I don't know the mechanics of how the claims actually move through the process. If Medicare is the primary, it would cross over automatically. Would Medi-Cal pay anything? Depends upon whether or not the Medi-Cal rate is equal to or higher than Medicare. So that's what I'm going to have to find out the answer to.
Okay, and I'm just going to take Diana off mute real quickly to see if she has a follow-up question to that. Oh, I'm sorry, Diana. I'm not going to be able to unmute you because I think you have to enter a PIN in your screen in order to allow me to do that. But so we'll proceed on to the next question. Greg Kahn had a question about how does the duals program work with competitive bidding?
I have not seen any recognition of any limitation. I would assume that if they're in if they stay with their Medicare Advantage plan and opt out of the Medi-Cal, complete management of both sides of the equation, I have not seen any recognition yet from what Medi-Cal would do in that situation. Certainly, if they stayed and opted out and stayed with their Medicare provider, they would be limited to the Medicare competitive bidding. But I've not seen any explanation as to how that would be integrated. Again, I think these are two excellent questions that I will follow up with and provide information to members. I think sometimes we get an answer that they don't know because no one's thought through that far, but they are connected.
Okay, and I am able to unmute Greg. Greg, I'm going to unmute you so you can ask any follow-up questions of Bob. Do you have a follow-up?
Bob, I'm not quite sure what you meant by the patient could opt out. You're talking about opting out of the dual, but they can't opt out of competitive bidding. So is Medi-Cal going to coordinate the dual contracted providers with Medicare's competitive bidding contracted providers? Or are they only going to contract with providers that already have the competitive bid contract?
Yeah, I don't know the answer to that. It's a very good question, and I will pursue an answer. But I think when that particular question was raised in Los Angeles at the meeting we had in February, that they did not answer. I need to follow up with them and see if I can get a specific answer to the question. The opt-out provision is only for the Medicare portion. So as I said, you're not opting out of the Medi-Cal side. You will be in Medi-Cal Managed Care. The question is who takes the lead there in terms of how services are provided and how they're paid for. I don't know how that claims processing system would work. I know how Medicare works now, but I don't know how the duals would impact that. And would it then, to your point, require that that the provider only be one who has a competitive bidding contract for a covered piece of equipment or supply? So I need to find the answer to that.
Okay, so there are a couple of questions that have been submitted by Aaron Frazier. They're all pretty related to each other. The first being, is there an opportunity for advocacy surrounding the Assembly Committee hearing on AB 1805, legislative visits, attending a hearing, and then separately, is CAMPS considering a dedicated Sacramento Day this spring to help drive support of the bill?
Well, I think that we're not doing a separate day. I think that this is the time where individual contact, I think, is even more meaningful than doing a legislative day. I mean, the legislature now, starting this next week, kind of hits the ground in terms of all the committee hearings. They're a very busy time. They take a spring break, and then we're the end of April. So I recommend that you make those contacts directly. It's just as effective to contact the district office as a constituent as it is to come to Sacramento and build that relationship starting that way. And that all trickles up to the Capitol office. You can contact either one, district office or Capitol office. There will be hearings. The Senate will be hearing this issue on April 24th in the Budget Subcommittee. I will be there. There will be opportunity for public comment. The public comment is limited in terms of time to 1 or 2 minutes. Anybody who wants to come to Sacramento and get up and speak about their impact, I'm happy to have you here and do that. That is an opportunity. The Assembly has heard the issue already. We had actually Amy Casey from ATG sat on a panel at that initial hearing. The item is what they call kept open, meaning no resolution was taken. They won't take any resolution until after the May revise when they know more about the current budget surplus. So there are opportunities if people want to come. I think, to my mind, the greater focus, the greater benefit is doing direct outreach to individual Assembly and Senate members as constituents.
Okay, and Aaron said thank you, Bob, for that. Also, Lori Chilton had a question which I can quickly answer. Just to remind everybody, we will be sending out this PowerPoint presentation. It'll probably come out to you guys on Monday because we'll also plan to send the recording of this webinar along with those with the PowerPoint handout. Another question from Michelle Knowles, payment question on the 10%. Can we ask the program to add some sort of indication on the electronic payment loop on a per paid claim basis, indicating the 10% was taken, how much it is associated with the cut, eliminating the manual process for finding the 10% and reconciling accounting on the provider side? And if Michelle's still on the phone, I will go ahead and unmute her. So as you're answering that, if there's any follow-up questions.
Yeah, we're still waiting for the details, and the timeline for how this is going to be done. As I said, the department's initial conversations with me were that they would be sending out a notice in advance of any take-back to each individual provider indicating what the dollar amount of the take-back was calculated to be, and then beginning to do that on a per-check write basis over a period of time. I don't know the mechanics of how that would be reflected, whether you would see an adjudication of the past claim, re-adjudication of the past claim paid amount, and what that reduction was. I have not got that level of detail yet from the department or from Xerox as to how they're going to do it. So I think that's something, again, everybody's asking very good questions that I need to follow up on and get more specifics. But in some cases, those answers are, I asked for them, but they're simply not available because no one's got to that point yet. You'd think they would have if they were going to be doing it in April, but my feeling is that until the May revise is done and until those discussions between the legislature and the governor occur in more earnest, I don't expect that they will begin to do the clawback for fear that it might be undone or might be adjusted. So my my sense at this point in time is that they'll wait until May or perhaps June if they do go forward before they do go forward. But again, just my intuition.
Okay, so we have one more question, and the question is, do we have a time frame of when the additional 5% cut will be implemented in regards to enteral formula?
I believe that you should have seen that now, that it should have started as of February 7th. I know I've heard Medi-Cal requires you to be a pharmacy provider to dispense Enteral, and I heard from several providers that they saw the reductions. So my assumption is it's in effect now.
Okay, and at this point we have no other questions. I don't know if you want to wind it down anyway, Bob, because we're right at an hour.
Right. Well, I want to thank all of you for participating. I want to thank you for your support of CAMPS and ask you to continue to do that. Again, some great questions that I will pursue and get some answers out to people. We may do this again. Hopefully, we'll have a positive outcome here, and we'll have good things to report to you going forward. If people need help in doing any outreach, we're happy to help you with that process. But let's make some noise and get this thing undone. Thank you all.